Good afternoon, everyone. Before we start our invited talk, I will briefly remind us what Ada Lovelace is famous for. She is the daughter of a famous poet, Lord Byron, and she was born Augusta Ada King, Countess of, she was born Augusta Ada Byron, and then she became Augusta Ada King, Countess of Lovelace. She showed her gift as mathematician at a very early age. Her mother, who was also a mathematician, believed that engaging in rigorous studies would help Ada develop self-control. And mathematics and sciences that were not the standard subjects for women at the time were chosen to protect Ada from developing her father's moody and unpredictable poetic temperament. Working with Charles Babbage, Ada took part in writing the first published computer program. She was a computing visionary, recognizing for the first time that computers could do much more than just calculations. She died from cancer at the age of 36 on November 27, 1852. So is today Ada's birthday? No, it's not. But as the founders of the day explained, the second Tuesday in October was chosen for its convenience, and it is never the wrong time to celebrate women's often downplayed accomplishments in the sciences. Today, we are celebrating women's accomplishments in STEM by introducing one of our own accomplished computer scientists, Dr. Lola Ogunyemi. Dr. Ogunyemi is the director of Charles Drew University of Medicine and Science Center for Biomedical Informatics and a professor in the Department of Preventive and Social Medicine at Charles Drew University. She is also an adjunct professor at Radiological Sciences in the David Geffen School of Medicine at UCLA with the Medical and Imaging Informatics Group. A high school Pascal programming class led her to major in computer science in college and in graduate school, where she learned about biomedical informatics. Dr. Ogunyemi was recently a principal investigator on an NLM-funded R01 that inspired some of today's talk. Her research focuses on novel biomedical informatics solutions and for the problems that affect medically underserved communities. Please welcome Dr. Ogunyemi.
Thank you so much, Dina, for the introduction. And I'm really, really honored to be here today to give the Ada Lovelace lecture. As Dina mentioned, I got into computer science just because I took a Pascal programming class in high school and really, got interested in the fact that I could make the computer do what I wanted, and I really enjoyed that. And so I went on to do undergraduate work at Barnard College in computer science. And the computer science program at Barnard at the time was not independent. Right at the present time, Barnard has its own independent computer science program. But when I went, all the Barnard women had to take the computer science courses for the major at the School of Engineering at Columbia. And so I had many classes where I was one of 2, 3, or 4 women in a computer science class. And so one of the professors, I think, decided to, make us feel at ease by telling us about Ada Lovelace and Charles Babbage and the analytical engine, and Ada Lovelace being the first computer programmer. So that was my first introduction to Ada Lovelace and her work. I wish I could say I have programmed in the programming language Ada, but I never have. But I learned about her early on in my undergraduate career. And again, I'm pleased to be giving this talk. So what I thought I would talk about is tackling diabetic retinopathy in a safety net healthcare setting. But I wanted to set the stage a little bit because I came from a computer science background where I got interested in biomedical informatics while in graduate school. Two of the adjunct professors in the computer science department at UPenn were clinicians. They were physicians, a radiologist and a trauma surgeon. And I wondered what they were doing in a computer science department. And so I was curious about their projects. And that's how essentially I found out about biomedical informatics and got sucked in, because I thought, wow, using computing to help physicians, nurses, and patients, that would be a wonderful thing to be able to do. And so my career has essentially been spent in the informatics field. So I started out after graduate school at Brigham and Women's Hospital in Boston. And from after 7.5 years at Brigham and Women's Hospital, I was recruited to start a Center for Biomedical Informatics at Charles Drew University, focused on medically underserved populations. So Charles Drew is a private nonprofit historically Black graduate institution and is also a Hispanic serving institution in South Los Angeles. It was established in 1966 in the aftermath of the Watts Rebellion. And its mission is essentially to graduate diverse health professionals, nurses, physicians, PAs, and so on, who are dedicated to social justice and health equity for underserved communities. The CDU Center for Biomedical Informatics was established in 2007. I'm the founding director. And the idea was to develop biomedical informatics solutions for medically underserved communities. The faculty in the center include computer scientists, an internal medicine physician, sociologists, public health professionals. And the center is funded by a mix of NIH grants, a CDU NIH endowment, as well as state and foundation grants. And our projects look to help underserved communities, as I've mentioned. So Charles Drew is located in South Los Angeles. Los Angeles has 8 service planning areas. They're just geographical partitions of the county. And Charles Drew's located in Service Planning Area 6, or SPA 6 as it's often called. And SPA 6 is it's larger than some states. It has 1.1 million people of predominantly Latino and African-American heritage, but it unfortunately also has a disproportionately low number of hospitals, clinics, and medical specialists. So a recent study found that 32.5% of adults in SPA 6 had difficulty accessing medical care versus 26% countywide. SPA 6 also has many areas that are HRSA designated health professional shortage areas. And so Charles Drew is doing its part to educate health professionals who can help to alleviate that shortage. So before I get going, I want to basically describe what the healthcare safety net is. So before I moved from Boston to Los Angeles, I really wasn't familiar with the healthcare safety net. And in the US, the healthcare safety net includes federally qualified health centers and lookalikes, as well as state and county hospitals that provide healthcare to approximately 16 million patients across the United States, and within California to about 2 million patients. And they provide healthcare regardless of the patient's health insurance status or ability to pay. So most of the patients are either uninsured or underinsured. So after I arrived at Charles Drew in 2007, I started working on different projects and, trying to move from the model I was used to, which was, doing things as a proof of concept, to transitioning from that to actually trying to implement projects that made a difference to, providers or patients and so on. And I had a colleague who was then an associate professor at Charles Drew in the College of Medicine, but also the medical director of a federally qualified health center, so a safety net clinic. And he had a patient he treated, as a primary care doctor, he treated a lot of diabetic patients, and he had a patient that he was very concerned about who, wasn't doing well in terms of his blood glucose levels, medications, diet. The patient looked to be in bad shape. And he was concerned about potential complications of diabetes, such as diabetic retinopathy, which could lead to vision loss. And so since the federally qualified health center is a primary care clinic, he had to refer the patient to see an ophthalmologist, which is considered specialty care, and so at a different facility. And so he referred the patient to the Los Angeles County Department of Health Services at the time. So the patient was referred, and the county on its part was getting referrals from their own ambulatory care centers, as well as FQHCs, which are independent and not necessarily affiliated with the county. And so they had to deal with a large volume of referrals coming in for ophthalmology services from within their own facilities, as well as FQHCs and lookalikes outside their facilities. And so this gentleman was put on a waiting list because, you know, it was first come, first served. And so he was waiting his turn to be seen by an ophthalmologist to get his eyes checked because his primary care physician was worried about diabetic retinopathy. Because of the large volume of patients waiting, 4 months into his wait, he went blind. And that, just hearing about this occurrence was just so shocking to me. I couldn't believe that something like that could happen. And everybody had seemingly done the right thing. He was referred, he was on the queue to be seen, but essentially ran out of time. And so we got talking and trying to figure out in what ways we could help try the situation. And so Charles Drew had a center grant at the time, and so I wrote a supplement with a bunch of clinicians to basically look at teleretinal screening or telehealth as a potential solution to address this problem. Now, I had never done a telehealth project before, but the dean of the College of Medicine at the time at CDU was an ophthalmologist who was interested in informatics and had done telehealth projects with a mobile van. In fact, I think he had received some NLM funding for that. So he was well connected and knew individuals who could basically assist us with the project. So we applied for a supplement and got it. So I'll give an overview, sort of a background of what diabetic retinopathy is. The pre-telemedicine screening process for diabetic retinopathy in inner city Los Angeles, you've heard a little bit about that, but I'll expand a little bit more on that. Our study goals, the methods, results, and discussion, and then I'll follow that with a follow-on project that we did based on the results of the initial telehealth study. So diabetic retinopathy, in a nutshell, is damage to the blood vessels of the retina caused by excess blood glucose from diabetes. If it's left untreated, it can lead to blindness, but if it's detected early, it's treatable with laser photocoagulation therapy. So it's not something where people should be experiencing vision loss if they're seen early. And American Diabetes Association and other guidelines recommend that people with diabetes be seen annually to get their eyes checked for retinopathy so that they can get treatment early. Unfortunately, diabetic retinopathy is a leading cause of blindness in working age adults in the US, people between the ages of 20 and 74. And it progresses from mild non-proliferative diabetic retinopathy through to moderate, severe non-proliferative diabetic retinopathy, and then proliferative diabetic retinopathy. And there are visual cues that emerge. So at different stages of retinopathy. So at the proliferative stage, there are fragile blood vessels that grow and can bleed and burst in the retina, and that leads or could potentially lead to partial or complete vision loss. So risk factors for diabetic retinopathy are well documented in the biomedical literature. An important one is the length of time a patient has had diabetes. So the longer a patient has had diabetes, the more likely they are to progress towards diabetic retinopathy. Another is high blood glucose. Being on insulin treatment is a risk factor. High blood pressure is a risk factor. High cholesterol. Diabetic kidney disease is a risk factor, nephropathy. Obesity is a risk factor. Ethnicity is a risk factor with Latinos, and in terms of race, African Americans also being at higher risk for diabetic retinopathy in the US. And smoking is somewhat controversial because some studies have shown that it has an impact on retinopathy and others have shown no impact. So in 2009, at the time that we received this supplement, 60% of adults across the US who had diabetes were receiving annual screening in accordance with ADA guidelines. But in this inner city safety net setting, less than 25% of adults were receiving annual screening in accordance with guidelines, which means that there was a disparity in terms of vision loss and impact in these communities. So there are a number of factors that impacted the disparity in inner city versus national screening rates. And one of them is what we've seen for SPA6 that I mentioned earlier, which is a shortage of specialists for retinopathy screening, a large number of uninsured or underinsured patients, and then something we'll come back to again later on in the presentation. Patients' own misconceptions about the utility of regular eye exams also plays a role in this disparity. So the process for retinopathy screenings in South LA, in the South LA safety net, before the introduction of telemedicine was essentially a diabetic patient would be seen at a primary care clinic, an FQHC or lookalike, referred to a county health facility for specialty for retinopathy screening to see an ophthalmology specialist. And then after 4 to 8 months of waiting, just because of the volume of referrals being received, the patient would be screened at the county health facility. And if they were found to have, for example, proliferative retinopathy, they would return for treatment. If they were found to have no retinopathy or mild retinopathy, they could wait another year to be seen. So the study goals for the supplement that we received were to assess barriers to and facilitators of using teleretinal screening to detect diabetic retinopathy. And we partnered with 6 South Los Angeles safety net clinics, FQHCs. And we wanted to know what proportion of images from teleretinal screening would be readable to eye specialists, and how acceptable teleretinal screening itself would be to patients as well as to clinic staff. And we also wanted to look at the proportion of diabetic patients who are at risk for retinopathy who received retinal screening in accordance with evidence-based guidelines and who required ophthalmology treatment and received that treatment. We obtained IRB approval for the study from Charles Drew's IRB and signed memoranda of understanding with the different FQHCs and the center. On our part, Charles Drew from the supplement funds purchased 3 digital non-mydriatic cameras for use in teleretinal screening, which means that some of the clinics had to share a camera and send their patients to another clinic to actually get their eyes checked. We also retained 3 board-certified ophthalmologists as readers for the project and arranged photographer training and certification in partnership with Dr. Jorge Cuadros, who is an optometrist and an informatician at UC Berkeley. And he's the creator of IPAC software, which is now widely used across the country and even internationally for teleretinal screening. CDU also agreed to weekly monitoring of clinic sites and troubleshooting. But one of the most important things that came out of the process was arranging with the county and the clinics to expedite treatment for potential cases of moderate or worse retinopathy. So the county agreed that patients who are flagged as having moderate or worse retinopathy from our study would be seen in the county within 3 weeks. And that was a major improvement in the situation at the time. On the clinic's part, we agreed to identify staff, so usually medical assistants, who would be trained by Dr. Cuadros on camera use. And the medical assistants, the photographers, took and uploaded patient retinal images into IPAC software. They made the referrals to county health facilities for follow-up care and provided our study access to medical records for abstraction. So image taking for the study occurred between 2010 and 2011, and then we had retrospective data collection between 2010 and 2012, collecting information on patient demographics, their medical visit history, referrals, their comorbid conditions, and different clinical values at multiple time points, like hemoglobin A1C, blood pressure, and weight. The readers for the study, as I mentioned, were 3 board-certified ophthalmologists, and they used the IPAC software to assess the presence or absence of microaneurysms, retinal hemorrhages, the visible cues that something is going on with regards to diabetic retinopathy with a patient. And they would also assess whether or not the patient had diabetic retinopathy based on the presence or absence of these microaneurysms, hemorrhages, cotton wool spots, and so on, and the severity of diabetic retinopathy if a patient had retinopathy. They graded the quality of images taken by the medical assistants and photographers in a bid to assist with quality improvement on that side of things. We also conducted a qualitative study of teleretinal screening because we were also interested in, as I said, staff and patient perceptions of teleretinal screening. And so Dr. Sheba George, who's an associate professor at CDU and a sociologist who's really interested in socio-technical issues, how introducing technology changes the relationship between, patients and providers, and the dynamics among staff even. So technology can have unintended consequences, and this is one of the things that she is interested in. So she, with a postdoctoral fellow, Allison Fish, and project coordinator, Erin Moran, had focus groups with 42 patients from the 6 FQHCs, as well as in-depth interviews with the clinic staff. We also assessed machine learning for detecting DR from electronic health records of 513 patients for whom we were able to get complete records, but I'll talk a little bit more about that later. So this is what the digital non-mydriatic cameras that we purchased look like. So they're big, bulky cameras. And this is just the study staff playing with the cameras. And the fellow in the blue shirt is Dr. Quadros from UC Berkeley. So the results of that initial pilot study were that we were able to screen 2,732 unique patients for diabetic retinopathy, but the total number of screenings were 2,876, because in some cases the image quality was not good enough for the readers to be able to make an assessment, and the patient had to go back and get images taken a second time. So in terms of the percentage of diabetic patients screened across the 6 clinics, that came to 29% of the diabetic patients. There were 9,432 across the 6 clinics. The number of patients recommended for referral was 1,035. Patients with proliferative diabetic retinopathy, so the stage at which there's fragile blood vessels that can bleed and burst and bleed and occlude the retina. We had 48 of those. We had 115 patients with severe non-proliferative diabetic retinopathy, 247 with moderate non-proliferative diabetic retinopathy, and 246 with mild. We also, one of the benefits of teleretinal screening is the ability to pick up other conditions involving the eye. So we're able to pick up glaucoma, age-related macular degeneration, as well as cataracts. And those patients were also referred for to be seen in the county, even though that wasn't, those were not diabetes related. So some of the barriers that we discovered to teleretinal screening include that the clinics lacked resources to integrate image taking for teleretinal screening into the primary care visit. So not all the clinics were able to integrate image taking into patients' visit with their primary care doctor. In fact, the 6 clinics, the clinics differed in how they handled this. Some of the clinics had 1 day a week where they would have the medical assistants just focus, like on a Friday, focus on image taking for diabetic retinopathy, whereas some of the clinics had like 3 days a week. In the morning, there would be a medical assistant available to take images. And we found that the clinics that had multiple sessions ended up screening more people, and that the clinics that had only a 1 day a week session actually had a harder, the medical assistants had a harder time keeping up with the camera skills, because it was almost like every week they were trying to remember again how to deal with the technology. Another barrier for teleretinal screening was that patients sometimes didn't understand the reason for their screening visits. So in the work that Dr. George and the team did, they found that sometimes patients, in spite of the fact that the clinics had medical education classes for patients, many of the patients thought that the teleretinal screenings had to do with visual acuity. And they're like, well, I don't need glasses, or, just not understanding the connection to their diabetes, even though they had been in medical education classes. So there's sort of a gap in knowledge there, or some kind of mismatch in terms of what was being communicated and what patients understood. We also found the need for an image quality rating cutoff for photographers. As I mentioned, the photographers were medical assistants who were already employed by the clinics, and fantastic at their jobs as medical assistants, but some struggled with reaching a suitable image quality rating, and would have to be, so the clinic would have to have a backup medical assistant and sort of transition. We found that there was a need to transition some folks from being photographers because they just weren't able to keep up the skills. And this is in spite of the fact that prior to photographers being allowed to take photos for the study, they had to receive an image quality certification from the IPACS team. So they had to take a series of images on their colleagues and have a team at UC Berkeley look at those images and basically determine that they were good enough quality for reading. But as we progressed with the project, we found that some photographers struggled to maintain that image quality. And so one of the board certified ophthalmologists on the study, Lauren Daskovich, set a cutoff for future clinical use in terms of quality ratings, so that they would know, if a medical assistant couldn't reach a particular quality rating, they needed to transition to another photographer who could. The facilitators of teleretinal screening in these settings were, photographers or medical assistants that were proactive about what was going on. So, and also a clinic environment that rewarded creativity for troubleshooting. So some of the clinics, so the digital non-mydriatic cameras rely on the fact that, patients' pupils can dilate naturally in a dark enough room, but some of the clinic settings did not have rooms dark enough for that to happen naturally. And so dilation was, using eye drops was one of the potential things that was considered. And some of the medical facility directors were hesitant about that because there's a potential for a very rare side effect, acute angle closure glaucoma. And they were worried that, if that happened in a primary care setting, there wouldn't be an ophthalmologist on hand to help treat the situation. So clinics that allowed dilation also saw better results than clinics that did not. And we did not have any cases of acute angle closure glaucoma in the study. Another facilitator of teleretinal screening was acknowledgement of the importance of screening by clinic staff that were not involved in the study. So a potential problem was, the photographers were medical assistants and other primary care doctors pulling them off of camera duty to do other things. And we discussed that at the beginning of the study, but we found that clinics that were able to give the photographers more space to focus on photography had better outcomes than those where the medical assistants were being pulled off camera duty to do other things. And then another facilitator was incentives for photographers to maintain or improve upon their skills. So given the screening rate that we were able to achieve in that pilot, it got me thinking there's still a number of people who needed to be seen, but basically weren't able to be seen in the pilot. And I started wondering whether it was possible to detect whether a patient had diabetic retinopathy based on information. And so we knew about the risk factors. So information on the risk factors from their electronic health record data, because we didn't have image data for them. So the only thing we had to work with would be risk factor data in the electronic health record. So we pulled data for 513 patients. We were able to get a complete data set for them, and created machine learning models for diabetic retinopathy on those patients. And we were able to create an ensemble of weak decision tree learners that received, that had a 69% sensitivity, 56% specificity, and an error under the ROC curve of 0.72. So it was moderately predictive of diabetic retinopathy. But that encouraged me, because I thought we could probably do even better than this. So after our teleretinal screening study completed, the 6 clinics continued to perform teleretinal screenings for diabetic retinopathy, and used they engaged optometrists in place of the board certified ophthalmologists that had been paid by the study. And so they were now paying for optometrists on cost and convenience grounds. And then the county rolled out at the time a new referral process using e-consult, which helped to streamline communication between the primary care clinic, which was independent of the county, and the county, so that physicians had a better idea of what was happening with their patient after they were referred to the Los Angeles County Department of Health Services. But most importantly, DHS established a teleretinal diabetic retinopathy screening program that basically accepts patients from all safety net clinics in the county system, and will eventually accept patients from all FQHCs in Los Angeles. So I wanted to acknowledge the many people who made the study possible and its success. And the 3 board certified ophthalmologists on the project were Lauren Pedy-Daskovich, Miguel Unzueta, and Michelle Banks. And Lauren was especially instrumental in, visiting the clinics, working with the medical assistants when they were having image quality issues, to try to understand what the difficulty was, and to get them to see the difference between a quality image and one that wasn't. And Lauren is basically the director of the county's teleretinal diabetic retinopathy screening project, so the entire countywide project. And many of the lessons learned from the pilot proved to be useful for that countywide rollout of diabetic retinopathy screening. And another important person to acknowledge is Dr. Quadros. I mentioned him before, but Angela Nassett at the time was the medical director of the MLK Outpatient Health Center, who helped to come up with a strategy of seeing patients identified by our ophthalmologists within 3 weeks if they had moderate or worse retinopathy. And without her input, that would not have been able to happen. So the work on the teleretinal screening study was supported initially by an NCRR center grant. The NCRR is now defunct, so it moved over to the National Institute of Minority Health and Health Disparities. And we had a number of publications from that study. So as I mentioned, the screening, so we were encouraged by teleretinal screening and what it could do, but still concerned about patients who really didn't have any idea, because one of the problems with diabetic retinopathy for many patients is that it's asymptomatic. So they didn't have any idea that anything was going on with their eyes. And they weren't going for the annual recommended screenings. And so we got thinking about how machine learning could help with assessing diabetic retinopathy risk. So we obtained an NLM-funded R01 study to look at 2 main things. One was to develop machine learning methods to detect diabetic retinopathy from data in electronic health records, and sort of an extension of what we did in the pilot, and with the goal of identifying and reaching out to high-risk diabetic patients who skip teleretinal screening for multiple reasons. And then we wanted to compare the sensitivity, specificity, and error under the curve of different machine learning approaches. And second thing that we wanted to do was to compare deep learning on digital retinal images with optometrist assessment of the same images, as well as ophthalmologist in-person eye exams of patients. So this is a partnership with UCLA and Voxel Cloud. Voxel Cloud is a group of UCLA PhDs, computer science PhDs that formed a company to look at diabetic retinopathy and other imaging type work. And so here we're looking at convolutional neural networks for staging and grading diabetic retinopathy. So for this talk, I'm going to focus on the first part of the study, which is looking at machine learning for detecting DR from data and patient records. So patients who are not coming in for the annual screening, and there's not necessarily an image for them to study, how do we identify that they are at risk and try to persuade them to come in? So for this, we partnered with the Los Angeles County Department of Health Services, which is the second largest municipal healthcare system in the US. It's second only to New York City. And LACDHS caters to about 750,000 unique patients a year. And about 142,000 of those patients are uninsured. It sees about 85,000 patients with diabetes. So between 2019 and 2020, the county saw 85,000 patients who had diabetes. And the teleretinal diabetic retinopathy screening program that's led by Dr. Daskovich has approximately 10 optometrists with ophthalmologists providing supervisory overreads for a large volume of diabetic patients. And so the objective for the screening program led by Lauren is to screen all diabetic patients annually per DHS guidelines. And with her program, the screening rates in the DHS improved from 37.7% in 2012 to 64% in 2019. And this was with the introduction of teleretinal screening, so very impressive. If you recall, I mentioned earlier that at the time we started, the national screening rate was about 60%. So they were able to get the screening rate from a low of 37.7% to close to the, essentially a little higher than the national average, which is pretty good. Now, these are the study staff on the grant. It's a multi-PI grant with myself and Ricky Tyra, who's in the Medical and Imaging Informatics group at UCLA. The sub-award PI is Dr. Lauren Daskovich with the County of Los Angeles, who leads the teleretinal diabetic retinopathy screening project there. And other study staff include an MPH student, Kyla Barron, who's a project coordinator, Alex Bowie at the also in the Medical and Imaging Informatics group at UCLA, Dr. Mayor Davidson, who's an endocrinologist and founder of the Venice Family Clinic in Los Angeles, who's on the CDU faculty and gave us advice with regards to diabetes and its consequences. David Heineman, who's a behavioral scientist, and many more folks. So just to give a background on some of the issues, one of the issues that comes up with trying to do diabetic retinopathy detection, essentially from EHR data. So here I'm going to talk about essentially class imbalances in machine learning. So if we have 1,000 patients and 900 of them don't have a disease. So if we're looking at retinopathy, we have 900 people who don't have retinopathy and 100 who do. So we have a data set with 900 negative training examples and 100 positive training examples. But what we want to do is predict the positive cases. We want to pick out the people who have retinopathy. This is an example of a class imbalance. And one of the interesting things is that a standard machine learning classifier can obtain high accuracy just by predicting that a patient does not have the disease. So to explain what I mean, in this situation where we have a 2x2 table that gives us, who has the disease, 100 people, who does not have the disease, and we have a classifier that simply just always says no one has the disease. It's not able to identify anybody who has the disease. The accuracy of this classifier would still be 90% just because of the ratio of people who don't have the disease versus those who do. Its sensitivity would be 0, so it's not really good at doing what we want it to do, but its specificity would be 100%, but it's essentially useless at detecting disease, but excellent at telling us who doesn't have the disease. And so there are a number of approaches to handling a class imbalance. One is to modify the learning algorithm to essentially penalize incorrect classification of the minority class, the class that we're interested in, but is not well represented in the data. There's also data pre-processing strategies to sort of try to rebalance the skewed distribution. So one is majority class undersampling, where we randomly essentially throw out cases from the majority class so that we have a balanced set of cases for the minority and majority class. And minority class oversampling, where we basically boost the number of examples from the minority class to match the majority class so that we have, again, a balance of classes in the data. There's also cost-sensitive approaches that combine algorithm modification and data pre-processing strategies, and the use of ensembles of classifiers that increase classification accuracy by combining the strengths of different types of machine learning classifiers. So the data source for our study was the Los Angeles County Department of Health Services ORCID Cerner EHR system. And we had available to us variables that corresponded to known diabetic retinopathy risk factors from the biomedical literature, variables that were suggested by clinician experts that basically speak to the micro and macrovascular complications of diabetes. So for example, we're trying to figure out what's going on in the eye, but we don't have images. So if we know that a person is showing signs of diabetic kidney disease, it might also imply that they're showing signs of retinopathy, that this process is going on in the eye as well. So we were able to obtain a training and test set of EHR records for type 1 and type 2 diabetic patients seen between January 1, 2015 and December 31, 2017. And we got 40,631 total patients. 31% of them had diabetic retinopathy, and almost 69% of them did not. And so our data set had a class imbalance, as I've mentioned earlier. And we also obtained an external validation set for the study. So these were EHR, so the training and test set were patients seen between 2015 and 2017. And for the external validation set, we had patients seen between 2018 and January 2018 and December 2018, who were completely independent of the patients that were used, whose data was used in the training and test set. So there's no overlap between the patients in the training and test set and the patients in the external validation set. So we had 9,300 total patients for the external validation set. And we had about 30 something variables that we initially looked at. There are more details on this in a recent JMIA open paper that was published this August. But we looked at socio-demographic variables, a general health overview, different clinical measurements, comorbid conditions that patients had, and all to try to predict a binary outcome in this case, whether somebody had diabetic retinopathy or not. With just the EHR data, we did not believe that we would be able to stage and talk about different sort of stages of retinopathy. So this was a binary decision. Does the patient have diabetic retinopathy or do they not? So the classification methods that we utilized or we assessed included random forest, support vector machines, extreme gradient boosting, an ensemble of stacked classifiers, the gradient boosting machine, random forest, and artificial neural networks, and then deep learning with a deep neural network. And we used two data pre-processing strategies to try to address the class imbalance. We tried both majority class undersampling, as I described earlier, and minority class oversampling using the SMOTE technique. we ended up dropping variables that had over 35% missing data. We dropped the variable on previous treatment of diabetic retinopathy because that was highly correlated with the outcome, and we felt that that was essentially like cheating. And we performed feature subset selection on the variables that were remaining. And so we got a feature subset of 14 variables, including age, sex, diabetic kidney disease, nephropathy, neuropathy, hemoglobin, insulin dependence, blood urea nitrogen, systolic and diastolic blood pressure, how long a patient had had diabetes, their ethnicity, their hemoglobin A1C levels, whether or not they'd had a stroke, and their triglyceride levels. We performed the analysis using both R and Python, and missing data was handled with K nearest neighbor imputation with using a K of 9. And we reserved a random selection of 34% of the data set as a holdout test set and performed tenfold cross-validation on the remaining 66% of the data, and assessed the best machine learning models from cross-validation on the test set as well as on the external validation set. And so just to summarize, so this table shows the model performance on the 14 variables from the feature subset using minority class oversampling on the test set as well as on the validation set. And with the test set, the best results, the highest AUCs were random forest as well as the deep neural network, but with different distributions in terms of sensitivity and specificity. And on the external validation set, the ensemble model did best for minority class oversampling. When we tried majority class undersampling, however, we found even better results than with minority class oversampling. So the best model in this case was the deep neural network with an area under the curve of 0.81 on the test set and 0.8 on the external validation set. And there are more details, again, in the JMIA open paper that I mentioned. So in addition to producing, to assessing different machine learning models, we then took another step, and based on the deep neural network that showed promising results using majority class undersampling, we're developing a diabetic retinopathy risk assessment, so web-based diabetic retinopathy risk assessment tool. So it's still a work in progress. We've received input from a number of different clinicians, endocrinologists, primary care doctors, ophthalmologists, and essentially it takes information on the 14 variables in the feature subset and allows a primary care provider to assess the risk of diabetic retinopathy. And what we have in mind is for example, FQHC clinicians who are concerned about their patients' risk of retinopathy. So they're not specialists, they're in a primary care clinic. They may not have a teleretinal screening program, but they're trying to figure out, whether to be more aggressive in pushing for ophthalmology, an ophthalmology referral, or making sure that the patient is moving along in terms of getting their eyes checked. So the risk assessment tool essentially provides different risk categories for retinopathy assessment. And the feedback from all the clinicians was that 14 variables was still too many. And so our model allows the clinician to input 6 variables and will impute the remaining 8, but obviously the more information, because it's doing the imputation based on the original training set, the more information that a provider can give, the better the model will be. But essentially it can take information on 6 variables or on all 14 or something in between those two and provide an assessment of diabetic retinopathy risk. So in addition to this, we've done quite a bit of outreach work. So we began an outreach study this July. So one of the things I had mentioned was that the screening rate in the county went from 37.7% in 2012 to over 64% in 2019 with the introduction of Dr. Daskovich's reading center. But then COVID hit, and there were pauses in screening just because of the pandemic, but there were also more of a reluctance of patients to go out and get screened also because of the pandemic. So we had always planned an outreach portion of our study, but we didn't expect it to be as many patients as ended up needing to be sort of reached out to. So we reached out to 31,072 LAC-DHS patients who essentially had missed an annual eye exam as of mid-2021, either due to the pandemic or other reasons. So from the study, we sent reminder mailers to 31,072 patients, followed up with robocalls and text messages if the patient had not scheduled an appointment within 2 to 4 weeks of receiving the mailer. And then we focus on machine learning a month after that. So applying the machine learning models, we were able to identify 7,521 patients who were considered high risk by the machine learning model. We removed patients who opted out of phone contact or who had no phone. So we had about almost 7,500 patients left. Almost 5,000 of them were primarily Spanish speaking, about 2,500 were primarily English speaking. And so we had bilingual health educators and a research assistant on the project who made calls starting in July. And this portion of the study concluded on September 29th, so about 2 weeks ago. So we haven't completed a full analysis of the data yet. But one of the things that struck me in our weekly conversations about the study with the health educators and the research assistant was an elderly woman that was reached, and she was, grateful to be called, but she told the person calling from our study that she had no intention of going in to get her eyes checked. She was worried about catching COVID, and she had made her own risk-benefit calculation that the possibility of losing her eyesight. So she was an elderly woman who lived with her daughter and felt that she had her needs taken care of at home. And the risk of losing her eyesight to diabetic retinopathy compared to the risk of catching COVID, she would rather risk losing her eyesight. So she made it very clear she was not going to go in to get her eyes checked. Now, the health educators and research assistants followed a script. So she did not volunteer information about whether she was vaccinated, but COVID was her main reason for not wanting to risk getting screened, even this late into, because we're calling between July and September. And this basically, really got me thinking about the ways in which the pandemic has affected people in terms of just routine or, relevant screening for health problems or, necessary care that people are foregoing because of fear of COVID or other reasons to do with COVID. And it ties in with a Radix supplement that Dr. Shiva George, myself, and Dr. Daskovich have looking at this exact issue. In 2020, Lauren had noticed in the county that there was over 1,000 patients who had, procedures that they needed, vision-saving surgery, different kinds of procedures across the county, who wouldn't come in to get tested for COVID in order to have the procedure done. And this was a significant cause of concern because these were needed surgeries. They weren't, there would be serious consequences for not having those surgeries, but patients were like, there was a requirement to get COVID tested before having the surgery, and they wouldn't come in to get COVID tested or to get the surgery. So this is our Radix supplement was looking at basically how to reach out to such people using a combination of machine learning and community health workers. And it continues to be a concern, but things changed with the introduction of the vaccine. And by April of this year, the concern about going in, because people were afraid that they would catch COVID in the hospital setting, had changed to because people were able to get the vaccines. So our work was funded by the NLM under this grant, and thank you for attending, and I would be happy to take any questions that you have.
Thank you very much for an excellent and very educational and inspiring presentation. And we have one question already, and it starts with thanking you for the talk. It is very interesting. I liked how you centered the patient in your study using focus groups and mentioning patient perceptions and issues that would impact success in screening. How did you come to adopt the patient-centered approach?
So because we had a team that included sociologists and anthropologists, we pretty much knew that just a focus on the technical wasn't enough. It's not enough to get things technically correct, because you're dealing with human beings and you have to understand their motivations. And so getting that knowledge and having, we had people who were very versed in community-based participatory research on the project. And so they brought that perspective in, and we knew that we had to get patient and provider perspectives on how to get things done well.
That is really an excellent point. And I'm not sure if we have other questions from in the email, but meanwhile, I have some questions of my own. And one of them is, we used to hear that we do not have enough girls in STEM. And now we sometimes hear, oh, we have enough girls in medical schools, we have enough girls in informatics. Where do you stand on this? Do you think we still have a shortage of females interested in STEM?
So I actually think we do, and I think it depends on what area of STEM. So you basically mentioned, medical schools have done a great job, and we now have almost a 50-50 participation rate in terms of women and men in medicine. But if I enter a computer science classroom, it's still going to be skewed more towards men. Same thing for math. So it depends on the field within STEM. And so I think some of the fields that have a shortage, so how to sort of have this imbalance, need to look at what other areas of STEM did to level the playing field and learn from those other areas.
That's a great point, yeah. And that, well, how did they encourage women to get to STEM?
Right.
So we all have about 2 minutes left. So could you tell us, and I think that's very appropriate because you're so passionate about diversity, so it's an appropriate ending for that excellent presentation. What does diversity in science look to you like?
So it's basically, having a representation of the different people in society that would be impacted by what we're doing in science. So it's racial and ethnic diversity, but it's also diversity in terms of, first generation students, making sure that we have people involved in science whose families have not traditionally been involved in higher education. So it's looking at it from, multiple standpoints. I've been very fortunate to work with a lot of wonderful students who may have been the first in their families to go to college, who basically have experiences being the translator for their family in terms of medical care as kids. And they bring a perspective to medicine, for example, that you might not find elsewhere, because they've had to navigate the adult world as kids and navigate, dealing with medical terms in 2 different languages, trying to help out parents or other family members, to negotiate the healthcare system. So I see diversity in all these different realms, and I think it's important that we address all those areas.
Well, great. And I see that we have your email address. So if people did not have time to type in their questions, I'm sure they will contact you directly, or they will contact NLM SD, and the NLM SD will forward the questions to you. So again, thank you very much. And I hope your talk that is recorded and will be available actually on the NIH website in a couple of days. Usually it appears under NLM NIH talks, and you can search for that. So for those who want to see it again, maybe visit some details, please go to the NIH videocast website and search for this excellent talk there. And I hope you can use it in your lectures and inspiring your diverse students.
Thank you again for having me. It was such a pleasure to join you.
Dr. Florence, do you want to say something?
Well, thank you so much, Dr. Ogunyemi, for a fantastic talk and a great example of how sometimes people think computer science is like outer space and not really here on the ground dealing with real people's problems. So thank you for giving us a great example of that.
Thank you for having me.
Okay.